every day I think, wow, I have this incredible opportunity to see these patients and to have such an important influence in their life. That to me is part of my spirituality and my desire to make an impact. For me, spirituality and being a physician are very intricately linked.
You're listening to Parallax from Radcliffe Cardiology in association with makeadent.org. Here is your host, Ankur Kalra, MD.
Hello, everyone. Welcome to another Monday and another episode of Parallax. My guest on today's show needs no introduction. I think every cardiologist knows who she is. Dr. Pam Taub is professor of medicine at UC San Diego. She is the director of Preventive Cardiology at UC San Diego, and is here with us today on Parallax. We've been wanting to do this for a few months, and our schedules have not aligned, and finally they have, so I'm very grateful for that. So without much further ado, and no other introductions because, like I said, everybody knows her. Dr. Taub, welcome on the show. Welcome to Parallax. Thank you so much for doing this for us.
Well, thank you for having me. It's my pleasure to be here with you.
No, the pleasure is ours. The honor is ours. Thank you. And, like we were discussing offline, there's so much to talk about with you because you have such a rich portfolio and so much to share with the cardiology community. We both, as physicians, give a lot of value, or have a lot of inherent value to leading a spiritual life as a clinician, as a physician, as a cardiologist. And so, whilst I can talk to you about a myriad of topics in cardiology, I think there is importance and relevance here, particularly in the environment that we find ourselves today, to specifically talk about how to lead a meaningful, mindful, and spiritual life as a practicing clinician, physician, as a cardiologist.
Yeah, no, I think it's a topic that's very close to me because I think about what's going on right now in our society with so much division, and I think about the way that I was brought up, and I was really brought up in a unique way. So my mom grew up in South India, and she grew up in an environment where she was exposed to every religion. So my mom was a Hindu, and she went to Christian school for elementary school and high school. And South India is really just an incredible intellectual community. And so she had friends from every religion. She had friends that were Parsis and Muslims. And so she would tell me when she was a kid, one week she would go to the mosque, and the next week she would go to a temple, and then she would go to church. And so she really brought me up with this really incredible philosophy that all religions are the same. They're about just being a good person. And she really encouraged me when I was growing up to go to church, whatever people invite you to, just go to and appreciate and enjoy their cultures and their traditions. And that's really how I've viewed the world, is that everything is really the same. It's just different representations for different cultures. And so we are in an era of division, and it would be nice for us to kind of re-vector and become more the type of environment, or create the type of environment that my mom always talked about and raised me in, and what I try to do with my kids, which is really expose them to everything and tell them about the beauty in every religion, every belief. And I think it also is important for us as we relate to patients of such diverse backgrounds.
Yes, I really like the word revector. We've I'm on the same page as you are, as you just mentioned, that we seem to have lost our way. Um, uh, and I don't know what has, well, maybe I know what has led to it. Um, and Revectoring is important. And I resonate when you shared your mom's experience in South India, I sort of resonate with that because as a kid who was born and raised in India, we celebrated Eid, we celebrated Diwali, we celebrated Christmas and Good Friday in my school, in our school, and we had all these holidays. Um, and like you said, I think every religion has amazing sort of universal teachings, which we all can learn from each other, and from different religions. And so, what I've in my own um, exploration or examination of theology, which I like to believe that I like to read religious texts from other religions, and I have read the Bible, and I follow the Bhagavad Gita. I think that religion um, is um, initiates or gives is the spark to what then leads to spirituality, which is very very personal. For like, your spirituality will may look different than mine, but I think the common initiating factor to each one's spirituality or spiritual exploration becomes with religion. Would you agree with that?
Yeah, I mean, but I think for some people, they're completely non-religious can still be very spiritual people. You don't necessarily need religion to be spiritual. I think you could be um, without religion, you could still be a very spiritual person.
Yes, and I agree with that. In your existence or in your being as a clinician, physician, a cardiologist, how has being spiritual um, facilitated or further expanded your professional life?
Medicine to me is really such a privilege and such a calling that I think my desire to be of service to others, which is part of my spirituality, drew me into medicine in the first place. I mean, every day I think, wow, I have this incredible opportunity to see these patients and to have such an important influence in their life, their trajectory, how they do based on some decisions I make. To me, is beyond powerful. And that to me is part of my spirituality and my desire to make an impact. And I think for me, spirituality and being a physician are just very intricately linked. And people tell you things that they would never tell anyone else. I mean, that when I'm in a room with the patient, it's very sacred, and I respect the privacy. I respect what privilege I have in learning things about that patient. Sometimes I'm told things that nobody else in their life has been told, and it's an incredible power that we have, and it always makes me really reflect, be have gratitude, and also really enhances my desire to make more of an impact. So I think it all feeds on itself.
Yes, you mentioned, or you bring about a point which I agree. I mean, the beautiful word that you use is sacred. That conversation is very sacred, and that conversation is privilege. I think I think of it in a very similar fashion as you do, in that as a human being, there is another human being. So the God in me has the privilege to listen to another God in another human being, or the same God in a different human manifestation. If you know what I mean, and I'm sure you do. And that alone is such a privilege. I mean, I know many times we tend to focus on some of the intricate or cool things, quote unquote, cool things we do as cardiologists. For example, doing a transesophageal echocardiogram, for example, or reading an advanced cardiac imaging study, or doing a complicated procedure in the cath lab. And all of that is fine and essential and required for excellent patient care. but I think even those conversations we have in the office and at the bedside and with families are part of um, the sacredness of our profession. And so I have, and personally, I have struggled with the concept of burnout because, like you said, this is a calling. For me, it's a calling. It's an expression of service, and service is the path to self-realization. In the spiritual texts that I follow or I've read, and so I wanted to ask you this, and I'll bring up a paper that I had the opportunity to author with a good friend of mine, Anu Lala, who I'm sure you know, and Kavita Chennai. And this we published this paper in 2022 in the European Heart Journal, and it drew inspiration from the Bhagavad Gita and talked about the conflict of burnout. And oh no, thank you for seeing that when it came out. So when you hear about burnout, um, do you? This is a two-part question. Part one is: have you ever experienced it or been at the cusp of feeling that maybe you are getting burnt out? And if not, do you identify with the concept? I'm not trying to brush aside its existence, but I want to understand it better because to me it still remains.
I think that burnout is real. And I think a lot of burnout, it's not from the patient interaction, it's more from all the burdens of the system. It's more from the documentation, it's more from all the paperwork and the logistics. Those are the things that I think can cause burnout. To me, I never get burnt out from the patient interaction. The things that I have gotten frustrated by and burned out from is, sometimes there's excessive paperwork that needs to be done. You have to get your charts done by a certain time, those those kinds of things. I mean, but patient interaction and the fundamental human interaction is what kind of drives me and what allows me to kind of get through some of the other aspects of medicine that do cause burnout. I do think that for some people, burnout can occur when there's a lot of challenging situations or when there's a lot of bad outcomes. When we see people dying in cardiology, and we deal with some of the sickest people, and that happens. Often in our day-to-day work. I mean, that can cause some burnout as well. So there's various factors that I think can cause burnout, and I think it's about recognizing what those factors are, and they're different for different people. For some people, it may be just all the administrative burden that can be overwhelming. Some people, it might be volume, having to work longer hours, lack of sleep. So it is something that's real, and it's something that we all face at some point in our career. And it's about how, as a community, can we help each other? And also from an institutional perspective, how do we provide better resources for people to recognize when they have burnout and how to overcome it?
Have you deployed any strategies or have you shared any experiences with colleagues who may have experienced burnout in your vicinity, that you maybe or approached you to have conversations on burnout? Um, are there any interventions or are there any quote unquote prophylactic um, measures that the organization has deployed or you have deployed in your own life, or helped your colleagues, participate in such measures where there is less burnout or there is no burnout?
I think a lot of it is being there for your friends and colleagues that are experiencing it. Sometimes it's a bad patient outcome that really triggers the burnout. And a lot of times, people just need to hear that we are all human. Things happen. Bad outcomes are part of our job. I mean, it's impossible to go through a career with never having a bad outcome, and it's just really creating that safe space where people can kind of talk to each other about how they're feeling. I think the way that I've helped colleagues is really figuring out what is happening that's causing it. Sometimes it's lack of recognition. Sometimes it's, they didn't get a grant that they worked really, really hard for, or there was something that they were trying to achieve that didn't happen. And so it's failure that sometimes contributes to burnout. And as cardiologists, we are such perfectionists. We're, very type A, very driven. And so for us, not achieving something really can put us on this downward spiral. And so it's again resetting these things that can be triggers. And this is where I think having a really balanced outlook on life and having a little bit of a spiritual outlook and realizing, the world isn't just about us and our little world and what we achieved and what we didn't achieve, but that there's just so much more, really outside of work. And sometimes also, one of the strategies for colleagues is really just having them reset, like take time away from work, get out of this environment and really get some perspective, and helping colleagues, covering colleagues who need to do that. Those are the ways that we as a community can help each other. But also there's mindset. You can give 10 different people the same exact problem and it will be perceived in a different way. Some people will take that problem and it will be so overwhelming and so stressful. And another person will view the same problem with a different lens and just take it easy. And it's also about teaching people how to view things in a more holistic way and in a more healthy way.
That's a great comment, on mindset. Have you seen in your clinical practice as you've evolved, from early career to where you are now, the evolution? I mean, I'm sure the evolution happens with each one of us. Each one of us are on their own spiritual journeys. Um, how has your mindset changed or evolved over the years, where you feel better adept or maybe optimized to handle a bad outcome or an adverse outcome? If if you want to share that with us, I think that'll be very insightful.
I think that a lot of it is just it comes with experience, but I remember being a very early career cardiologist, and every time a patient of mine got admitted, the first thing I would do is I would say, "What did I do wrong? What did I screw up on? Why did this patient of mine get admitted? Why did this patient have an MI?" And kind of really like figuring out, like trying to pinpoint my mistakes. And then as you see enough patients, you realize that there's just so many things that you have control over. You do the best you can with the current state of science and the evidence base. And then there's just some bad things that happen to people despite all the things that you try to do. And so it's experience and it's evolving and it's seeing kind of evolution of disease. I think a lot of us, when we start out right after fellowship, we still are on the mindset we have control over a lot of things. Especially as cardiologists, we're very used to the cath lab and, hemodynamics and things really responding in a predictable way. But there's so much that doesn't. I can tell you stories of people that have the perfect LDL, the perfect blood pressure. I do everything right, and they have an MI. And it's devastating. It's always devastating when a patient has a bad outcome, but it's also accepting that we don't have control over everything and we don't have knowledge over everything. I mean, there's still so much to be done from a scientific perspective in terms of improving cardiovascular outcomes. But I think that it is hard when bad things happen to your patients, your family members, and and it does take maturity and experience to be able to process that better.
You mentioned about control, and I'm going to bring that paper up again because that paper was Bhagavad Gita dichotomy of control and metric medicine. And I agree with you. Control is dichotomous in nature. There are things that you could control, like you mentioned, and then there are things you can't control. And that is where I feel having a healthy spiritual backbone sort of augments your existence as a clinician and as a physician and as a cardiologist in a field where things are like the universe are ever changing. They're evolving. They're constantly in flux. Um, how have you developed over the years? I mean, I know that some of us are inherently more spiritual than the others, and some of us do cultivate that bone of spirituality. How has spirituality helped you balance the lack of control in in your field of work as a cardiologist? Where things are constantly in flux and constantly changing.
I think it helps you realize that there are a lot of things that you can't change, but it also helps you have better perspective on what you can change and what you have control over. And I think it really is important in helping me deal with things such as a bad outcome that could happen with a patient. And just realizing that there are a lot of things that aren't under our control. I also think it drives my scientific curiosity and trying to figure out new solutions, and realizing that there is a lot that we don't know. And a classic example of this is some of the work that I've done in POTS, or postural orthostatic tachycardia syndrome. So when I finished my cardiology fellowship, I hadn't even seen one patient really with POTS. I think I read about it, and I heard that you do a tilt table on it. And then when you're thrown into practice, and I remember this young woman in a wheelchair that came to see me, and she was kind of towards the end of high school. She was just turned 18, and she couldn't finish high school because she really couldn't concentrate. She really couldn't do anything, and there was no diagnosis that had been made. She had about 30 or 40 doctors, and an incredible thick medical record of all the tests, MRI, EMG, every rheumatologic test, everything was done, and and she was basically told, "You're crazy. You just don't want to work hard. You just don't want to finish high school." And I had just thought, okay, let me just look at some hemodynamics. This thing just doesn't make sense. And I remember all I did in clinic was orthostats. And I had her, just stand up, and I checked her blood pressure and heart rate. And it was obvious to me that there was a huge difference between her sitting in the wheelchair and her standing up. And I made the diagnosis of POTS. And I started her. I went on Up to Date, and I said, how do I manage this? And I remember just going through reading it and saying, oh, okay, I could give her this drug, Florinaf, and I gave it to her, and then she came back a couple months later, and she was standing up, and she had actually finished high school. She had enrolled in college, and she had her life back. And that to me was like a wow, aha, spiritual moment where I felt like, oh my God, I made a simple analysis, and I made a difference in the life of this person. And that actually got me interested in this condition, which when I started practice about 15 years ago, it really was thought to be a disease of crazy women. and people who are just anxious. And now we're really understanding so much more with pathophysiology. I did the first clinical trial with a drug called ivabradine, which really helps these patients with POTS. And to me, that is one of the most fulfilling things that I've done in cardiology is been able to do a clinical trial, generate an evidence base, and to have so many people do better that are in the prime of their life and regain their lives back and being able to do normal activities. And so that really kind of ties into going back to spirituality. I mean, that impact that you can make. I mean, I don't think what I did was rocket science, and so much of what I learned about POTS I just read and I taught myself. But it's just an illustration of what anybody can do when you see a problem, when you see people suffering, is to think deeper, to if you're not going to do the science, but to at least look at the literature and start putting things together and just trying to improve a patient's life.
Such a great example, such a powerful example. And you may not know this, but I actually pull up your paper each time I have a patient with POTS, and I do the due diligence in going to the PDF, taking a printout, giving copy to the patient, and prescribing them ivabradine. So thank you for the work that you did. It's one of the most complex conditions I see as a cardiologist in clinics. And these patients, like the one example you gave, have seen so many different physicians from different specialties in trying to figure out what's wrong with them. More often than not, are young women who want to live a completely normal life, and are labeled as, different things, which, I think we shouldn't even mention. Um, and the ivabradine works like magic. I mean, I just saw a young 18-year-old, also 18-year-old, who I prescribed the medication, and her life has changed. So it's incredible that the work that you do in your ecosystem can have such incredible wide impact, even for some, yeah, for your colleagues. I mean, you may never know that this patient benefited from the work that you did, and that is the power of asking the right questions, and that is the power of the verve of service that you bring with yourself in your heart every day to your work, and with the idea that if I can help patients who cross paths with me, then that is spiritual work, that is a work of service, and that can lead to changing so many lives you wouldn't even imagine otherwise changing.
Yeah, and I think research, I realized a long time ago that, I could see a lot of patients and I could individually impact them, but then if I did research, that I could make a wider impact, and that is why, I mean, I love research. I love, asking questions. A lot of it's very mechanistic and figuring out, how does something, um, happen? What are ways we can, improve cardiometabolic health, improve quality of life. And I mean, in some ways, research is a spiritual path for me because I get so involved, like when I'm writing a grant or when I'm thinking about something, and I go so in depth and really try to decipher things that, haven't been thought about. I mean, I think another great example is some of the work that we have done in terms of intermittent fasting and looking at, mechanisms of why there could be some cardiometabolic benefit and understanding things like low-grade ketosis and mitochondria. It just really takes me on an incredible fun path.
Yes, and I think that's a great segue to maybe conclude our podcast, is talk about your work on intermittent fasting, and hear from the horse's mouth, as they say, hear from the expert on this. Um, So, what do you think about intermittent fasting? Because I know the literature has been divided on its benefits versus lack thereof. So, what do you think after the work that you've done and published on in this field?
Well, let's go back to how we started, which is talking about all the great religions of the world and how there's so much beauty and so much to be learned from every single religion. But if you go back to a lot of these ancient religious texts, in almost every religion, they talk about fasting, which is really fascinating. In Christianity, there's a period of fasting. Islam, a beautiful example with Ramadan about a period of fasting. Yom Kippur for Jews. Hindus engage in various types of fasting. So it's really interesting going back to kind of ancient texts and really what intermittent or time restricted eating, which is the type of research we do, which is just really restricting eating to a certain period instead of eating all day long, um, is really going back to kind of what the wise sages and the ancient religions were talking about. There's some really beautiful passages if you look at all the different religions. For instance, in some Hindu texts, they talk about eating slow and stop eating when you're full. And it seems like such a interesting concept, but if we just stopped eating and we ate when we were full, think about all the cardiometabolic disease that wouldn't be there. So getting back to this concept of fasting, it's really about going back to how our ancestors lived and the hunter gatherers. They woke up in the morning when the sun came out. They ate food. They worked really hard. They were usually doing a lot of physical activity to gather that food, and then they stopped eating when the sun set. And so that's really from a biological and evolutionary perspective how our body is supposed to function. Is we are supposed to have food for a certain period of time, but in modern society where we have excess. I mean, we live in a society where we have access to food all the time. And most of my patients will be telling me that they finish dinner 8 or 9 o'clock at night. Then they have usually a glass of wine or a snack. Then they might try to get to bed, but a lot of people have disrupted sleep and sleep apnea. So they get up in the middle of the night to go to the bathroom, or because they have sleep apnea, then they have another snack. So it's this constant barrage of stimuli into the body that's not good for it. The cells need a period of metabolic rest for cellular repair and important processes like autophagy. And so it's really kind of going back to the way we were supposed to eat, which is for a finite period of time. And all of our studies with time restricted eating are telling people to eat for 10 hours and to fast for 14 hours. And you don't have to get those numbers perfect. There's a lot of my patients that will just, their fast is 12 hours. And most of that 12 hours is when they're sleeping. So you tailor it to what a patient is able to do. But I start by really advising patients to eliminate their midnight snacks, to move up their dinner time to an earlier time, just starting simple and then eventually trying to get to a 14-hour period, because we've shown in our studies that people who have metabolic syndrome, especially when they do time restricted eating, they have a lot of cardiometabolic benefits, including decrease in weight, blood pressure, atherogenic lipids, and hemoglobin A1C. So that's the kind of fasting that we recommend, but there are extremes. I mean, there's these biohackers that do 3 days or 4 days of continuous fasting, and then they eat for 2 days. Those are extremes that I don't recommend. It's really kind of doing what our bodies are supposed to do, which is have that period of metabolic rest. And so I think when you look at the data, especially in patients with underlying cardiometabolic derangements, mildly elevated lipids, increased weight, et cetera, you see that there's a benefit in that population. And that's where our data really is in patients who have metabolic syndrome or underlying cardiometabolic abnormalities. There has been some research, and especially an abstract that came out last year, saying that fasting increases risk of cardiovascular events, but it's really an abstract that was criticized for having a lot of different confounders, including a large number of smokers in the population that had a higher event rate, a larger number of Blacks who also have more cardiovascular events. So it was really a very flawed analysis, and this is why you have to do prospective randomized controlled studies. And one of the things that we really need in the period in the field of intermittent fasting is long-term studies. Most of the studies are 3 to 6 months. What we really need to do is have people do it for a year or more and follow them out long term. But what's really interesting is we have natural experiments with different religions where people or sects within religions where people basically do that. Like I know, for instance, there is a group within Hinduism called Jains that basically really don't eat after the sun sets, and those people have a really great longevity. So we can kind of start looking at different natural experiments to get that long-term data. But in general, I think that the body of evidence shows that time-restricted eating, when done in uh, a reasonable way, not in an extreme fashion, helps with cardiometabolic disease.
Yes, it's brilliant how you answered that. For us, I think tying your work to spiritual foundations. And I always, when people ask me about Hinduism, particularly in North America, I mean, it's sort of changed now because more people have become aware of Hinduism. But when people have asked me, patients, particularly in the Midwest, when if patients have asked me about Hinduism, I've said more than a religion, it's a way of life, and that's what spirituality is. It's a way it's the way you live, and many examples of many days or nights, the 9 nights as we call them, where Hindus observe fasting. It's a very natural way of living. What a great answer. I think it would be fascinating for listeners to hear this, from a scientist of the caliber of yourself, that it was the underpinnings in spirituality which led you to undertake studies in intermittent fasting and POTS. What a beautiful way to conclude the show. Any closing remarks, Dr. Taub, for our listenership, for early, mid, late career cardiologists, for fellows in training, and for Parallax?
I think that you pursue your curiosity. Don't let anyone tell you that this is the way something has to be done. If you can think of a way to do it better, put yourself in an environment where you're going to have supportive colleagues and show that path. Because when I started 15 years ago as faculty at UC San Diego, nobody had really even heard of preventive cardiology. I mean, it was really kind of this weird concept to many people. I would get made fun of and said, "What is preventive cardiology? Is it just giving somebody a statin?" And at that time, the field was very primitive. If we just weren't thinking about preventive cardiology, but based on so much of the research and the data that has come out, we are now really understanding prevention in a more sophisticated way. We have the imaging tools to detect subclinical disease. We have really powerful categories of drugs like the GLP-1 receptor agonists, SGLT2 inhibitors, really powerful lipid-lowering drugs. And so there's just so much more that we now have available to us in preventive cardiology. And of course, there's lifestyle. And that's where I really want to make sure that there's evidence-based lifestyle recommendations, because there's so much garbage out there, and people, especially vulnerable people, are preyed upon by the supplement industry and by people that make all kinds of ridiculous claims that X strategy will make them live longer. And so I think as a cardiology community, as researchers, we need to do the studies. We need to generate good evidence to guide our patients. And that's also part of what we talked about in the very beginning about, my calling and my draw to cardiology and to research, which is to make an impact that's way bigger than me. And when I hear you telling me that you pulled out my paper and you helped a patient, I mean, I can't even tell you how incredible and how humbling and how grateful I am to hear that story and to think about that patient. And I think that, I'm not, this, I mean, I always tell my kids, I'm definitely not the smartest person. I'm probably like the most average intelligence person, but I'm just curious and I'm hardworking. And so what I would say to trainees and others is you don't have to be the smartest person in the room, but if you care, if you are curious, you can make a huge impact.
Excellent. Well, this has been just such a fascinating conversation. Thank you so much again for your time. Thank you for being on Parallax. You've been an amazing guest. I'm sure many of us will find this episode fascinating and thought-provoking. And to the listeners who have tuned in on another Monday, thank you for listening. Thank you for being with us for these past 7 years. Do let us know who you want to hear from. We value your feedback. Do share your feedback with us on SoundCloud, on Spotify, on Apple Podcasts, other platforms that you use to listen to Parallax. And until other Monday, have a good day.
We hope you enjoyed today's podcast produced by Radcliffe Cardiology in association with makeadent.org. We aim to bring you a new angle of all things cardiology every second week. Review us on your favourite podcast app or send your comments or questions to podcast@radcliffe-group.com. To view the series, head to radcliffecardiology.com/podcasts/parallax. Thanks for listening.